Imagine waking up with a severe headache, a high fever, and a stiff neck. Within hours, you could be facing one of the deadliest infections known to humans, meningococcal disease, caused by the bacterium Neisseria meningitidis. This rapidly progressing infection can lead to meningitis, septicemia, and even death if not treated promptly. In this video, we'll dive into everything you need to know about this deadly disease, from its symptoms, pathogenesis, diagnosis, and treatment. Okay, so let's start off with defining what meningococcus is. So meningococcus is a type of bacteria called Neisseria meningitidis. It usually lives in the nose and throat without causing problems. For normal individuals, it's part of the normal microbiota, but sometimes it can invade the body and cause serious infections like meningitis or blood poisoning. Now, this is what Neisseria meningitidis looks like. So if you're familiar with microbiology terminology, which we'll literally get into now, this is called a diplococcus or diplococci. So let's talk about the morphology. So the shape, it's a diplococcus, which means basically like a two-sphere. Spherical coccus means spherical and diplo means two. So you can see that it's like two spheres fused together. So that's diplococcus. And kidney shaped. As for the gram staining, it stains gram negative. And it has a capsule, which is a very important virulence factor that when we talk about pathogenesis, capsule is going to be the most important aspect. So it has a polysaccharide capsule. Let me zoom out. Yep. So it has a polysaccharide capsule, which is a key virulence factor that helps the bacterium evade the immune system. So this is the main function of the capsule, and it's what makes the infection very violent and life-threatening. It also has hair-like appendages called pili, or I think they're pronounced pili. It's like hair-like appendages. You can see there are so many of them. They're the yellow threads around it, and they protrude from the surface. And these pili are important for the ability to adhere to host cells. So unlike flagellated bacteria, the pili aren't really for motility. It's more to help adhere to the host cells, particularly the mucosal cells in the nasopharynx, because the nasopharynx has a lot of airflow and it could easily get swept away. So they need that mechanism in order to survive. Okay, now let's talk about the disease. So let's do a quick introduction. So meningococcal disease is a series and potential life-threatening infection. It is the leading cause of bacterial meningitis. Meningococcus is the leading cause. A condition characterized by the inflammation of the membrane surrounding the brain, which are the meninges, as we talked about. Neisseria meningitidis can cause also septicemia, which is blood poisoning, and all other severe infections, maybe more prominently in immunocompromised patients, and it can progress to fatal consequences if not treated quickly. Okay, so the first part of the disease that we're going to be talking about is the pathogenesis. How does the disease actually happen? what causes the symptoms and what makes it so fatal. So when we talk about pathogenesis, we're mainly concerned with virulence factors and mode of transmission, colonization, and dissemination, which is also a mode of transmission and development. So there are four main virulence factors. First of all, it's the capsule, which we discussed in the morphology section. As we said, it helps evade the host immune system by preventing phagocytosis. So mainly the main part of the immune system that is being evaded here are phagocytes, which having a capsule makes it hard to encapsulate the pathogen within the phagocyte vacuole. The second is pili. As we said, it's important for attachment. The third is the lipo-oligosaccharides. Now, these are endotoxins, and for most bacteria, the endotoxins trigger an inflammatory response. So it can cause this is what causes meningitis. Basically, meningitis is the inflammation of meninges, and the oligosaccharides are the endotoxins that trigger the inflammatory response. The last one is the IgA protease. Now, IgA is immunoglobulin A. It is a antibody of the human immune system, and this specific protease can break it down, which is also another mechanism to bypass immunity. Now, colonization, we talked about it, that they're usually present on mucosal surfaces of the nasopharynx. And transmission can spread through respiratory droplets. So this is how it can be transmitted from one person to the other, because it's in the nasopharynx, so it makes sense that it spreads through respiratory droplets. And after the infection, after the transmission happens, it can cause dissemination, so they can invade the bloodstream, leading to bacteremia, and from there, following the blood circulation, they can reach the blood-brain barrier and cause meningitis. Okay, so the next part, really quickly, we're going to be talking about the clinical manifestations. So as we said, there are two things happening. There's meningitis. This has its own manifestations, and if there is septicemia, this will also have different manifestations. So let's start with meningitis. These symptoms grouped together can be referred to as meningism, which is headache, fever, nausea, vomiting, a stiff neck, and photophobia, and an altered mental status. These are for meningitis. And for septicemia, it is characterized by a skin rash, by purpura, hypotension, and multi-organ failure in severe cases. And this picture right here shows the purpura, and there is hypotension, so usually you'll find in the lower extremities, there will be, if it develops way too fast, it can lead to severe skin necrosis, for example, in the feet. Okay, now let's talk about the diagnosis. How do we diagnose a patient that we suspect might have meningococcus or meningococcal disease? So first, as we diagnose anything, we want to know the history. So in this case, we're going to be asking about if they have traveled to any area that is where this disease is endemic, for example, sub-Saharan Africa. We're gonna ask if they have been vaccinated for meningococcal disease, and as for the symptoms, we talked about them before in the clinical manifestations section. So meningism, so neck stiffness, and to support that, the physical exam findings. So there are two physical examinations we can do. So the Brudzinski sign and the Kernick sign. So these indicate severe neck stiffness and severe hamstring stiffness. So Brudzinski sign, because if the neck is so stiff, when you flex it, the knees will also flex. So that is a positive indication. And Kernick sign is when you flex the hips, the hamstrings are very stiff, so the person can't extend it back voluntarily, or it's very, very painful. So that's for the clinical evaluation. Now for the laboratory diagnosis, so this is a very clear case of CSF analysis, which you can do a lumbar puncture, where we basically inject a syringe, or we place the syringe below the spinal cord and into the subarachnoid space, and we take a CSF sample for analysis. So what we're looking for here is a high white blood cell count, which indicates infection, low glucose levels because the bacteria can consume glucose, and high protein levels like antibodies, etc. We can also do a culture, so isolation of Neisseria meningitidis from CSF. After isolation from the sample, whether that be CSF or blood, or even a nasopharyngeal swab, we can place it on a culture. We can also do PCR or polymerase chain reaction, where we can test for the DNA of Neisseria meningitidis. And lastly, we can do a gram stain, where we can identify the diplococci based on the morphology we discussed earlier. They're gram-negative diplococci in the CSF. So all of these can be done simultaneously, and we can't just depend on one of them, because there are many infections. There are millions and millions of microbes and bacteria and different strains. So we need to use a combination based on each specific case in order to identify and diagnose this properly. Lastly, we're going to discuss the treatment very quickly. So the first line treatment is intravenous ceftriaxone or cefotaxime. We give it intravenous because we need to work quickly, so we can't give it orally, for example. Alternative options can be penicillin, depending on resistance patterns, but this is not usually effective because most strains are resistant to penicillin now. Then obviously supportive care, hydration, pain management because it can be very painful, and monitoring for complications. And as for prophylaxis, so for example, if the patient is in the ICU, or their family members or the nurses and doctors, they can take rifampin or ciprofloxacin because they are considered close contacts. So and that's it. Thank you for watching.